finally, I'd like to deal with this issue about the junior and senior staff and in difficult situations. I just come up with that. So this is, because I'm in the older generations and I know a lot of older generations like myself, they doesn't have very good views about the younger generations. The children love luxury, bad manners, contempt for the authority, show disrespect. They no longer rise, they contradict their parents, chattel, gobble up across the leg, and tyrannize their teachers. Guess who? Guess who actually said that? Right? Uh, it's actually from Socrates. That is how many? 470 BC. So as you can see, Socrates is a very old generation. So the younger generation, in fact, are doing quite well. So we shouldn't have a biased opinion of our younger generation. I think they are doing their best to do that, and all societies should actually encourage and nurture the younger generation because our concept of thinking might be different. And these are the reasons why our junior healthcare staff is getting very burnt out. These are the many reasons. Parenting and schooling are different. They're more nurturing, less reprimand, but we get huge expectation and having the perfection complex. I think all the tiger mothers of Asia would have know about this. Our healthcare is getting more complex there, and our junior staff are new and learning. Our public healthcare standard is very high, and then when there is errors of suboptimal service, adverse outcome, they are scrutinized very much more. The patient expectation of care and services is very high and not conducive to learning or its learning curve. And IT has many issues, even if you are young and for older folks like me, I have a lot of difficulty with IT, but even for the young, they also have an issue. It can be a nightmare to try, to work with established ground processes. I presented last time about whether our junior healthcare professionals in Singapore are more likely to have burnout, and you can actually watch the video here. It's in the YouTube itself. And indeed, that they have, and we look at the various aspects in terms of the burnout itself, and we know that, in fact, allied health do have quite a lot of burnout. In terms of the emotional exhaustion, the allied health is much more than the non-clinical compared to medical and nursing, right? Medical nursing, allied health have high burnout, but allied health is the most. Depersonalization, medical has the most. And then in terms of the low accomplishment, the non-clinical actually has the highest itself. So that is actually the reverse. Okay, and I look at it, and I study the doctors and nurses, right? In terms of all the scores and the low accomplishment, they increase significantly when in the younger age group itself. So those with more than 30 years experience to less than 35, it increased significantly. The burnout actually increased for the doctors, for the nurses, for the allied health, and also for the non-clinical staff as well. And I even calculate according to medical house officer, medical officer to senior consultant, and the rate actually increased. If you are the senior consultant, okay, it's 26.7 burnout, right? But as you go on higher to the house officer, it's 53.8% burnout. So the conclusion is that junior healthcare professionals of all domains have higher burnout in all three categories of the burnout. And this higher prevalence is, as I mentioned, all groups of healthcare professionals, and there's an urgent need to address this, and priority should be given to them. And which is why in our task force, the job cover, we actually, the first three group, and this is the only three main work group that we do, is for all the doctors and all the groups to look at three. One is call coverage, the other is the ward rounds, and the other is results acknowledgement, because these are the bugbears of junior hospitals. The call for junior hospital, if we are not monitoring the hours, they work one whole day, that is 24 hours, and they work again up to the afternoon, another 12 hours continuously, which is 36 hours. And sometimes you're not careful, it goes on to 6 and then 12, 36 hours in total. So we're trying to reduce it to now just 24 hours if we do, or maybe just about 30, another 60, 30 hours, and not like, 24 plus 12, which is 36 hours, right? The ward rounds, there's multiple ward rounds because various grades of people are coming around. First you have the HO pre-round, then the MO rounds, then the registrar round, then the consultant round, and the head of department round. So there are 5 rounds, and you are actually putting a lot of stress to the junior doctors. We're cutting down just to 1 round. And this is one of the success of the work group itself. Resource arrangement, how the junior doctors can be spared from reading this, when it's on call, right? So just to mention about psychological safety, this is one of the ways by Timothy Clark of looking at psychological safety: inclusion safety, learner safety, contributor safety, and challenger safety, which is to challenge others' ideas, and that is the last grade. In IPSQ, we have a different way of looking at the safety. First is the inclusion safety. Then we have the speak up safety. You are able to speak up, right? The the level is the partner safety. The partner feel ability to respond and safe to respond. And then number 4, which is the most difficult one, is actually people feel safe to speak or respond in a conflicted or difficult situation, right? So what I mean by conflicted or this, these are the difficult situations when there is a error, adverse outcome, procedure that didn't went as well as expected, and we are involved. When there is staff abuse, right, blaming incivility, when there's patient harassment from patient. So these are the issues, and we have taken ways to try to resolve this. Firstly, of course, is the victim of the medical error, right? Is the patient. But at the same time, there is a second victim because the doctor or the nurse or the allied health feel very bad about it. And they can go into anxiety, depression, then self-doubt about themselves. And this issue was raised by Albert Wu, whom is one of our fellow patient safety expert in WHO. He first raised it in 2000. Medical error, the second victim. The doctor who makes the mistake needs help too, right? And here there's a study which shows that the second victims do suffer really a lot, sadness, depression, some of this. So what we need to do, as mentioned, in fact, yesterday as well, maybe a bit today, is that we should change from a punitive healthcare culture to one of transparency, a just culture, a balance to look at accountability and learning. And we should strive to support this learning culture and to be able to have the choices to do it as well, and to provide care support and peer support to those who are involved. So this is the reasons way of putting at it. If a person is really blameless because there was no malice involved, he was not impaired, he was just doing his job, and another person would have done the same thing, then the person is actually so-called blameless. And it's not really, the system maybe is more accountable. So we look at it from this point of view. If there's human error, in fact, we should console the staff because the staff may be depressed, right? If it's an at-risk behavior that there's a choice they made, to do shortcut, then we need, and for good reason, because they want to get it done, because, there's a lot of patients, and then we need to coach and maybe think of ways to help the person. But if it's willful behavior, then we, after going through it, we will, of course, will need to discipline the staff. That's according to David Marks. At the same time, we also have a task force that comes up from our Singapore Work Group for Prevention of Abuse and Harassment of Healthcare Workers. That is abuse from the patients, and the task force has worked very hard and come up with several programs. In view of time, I wouldn't go into detail, but just to say that, they established a severity classification of the abuse, because depending on the severity, we will act accordingly itself, and we define what is unacceptable behavior by the patient, right? For example, violence, shouting, abusive language, right? And then we say there should be zero tolerance to abuse and harassment, because it's causing our healthcare staff to have poor well-being, right? And we do have current measures now to be able to deal with the SingHealth zero tolerance approach. We send our staff for training on how to deal with aggressive behavior by patients and visitors. We have support programs as well. And we even have a chart, action plan to depend on the abusive episode. Because if it's just abusive by one patient and perhaps there is no need to take very much action. You need to be able to respond appropriately. But if it's a very severe, abuse, like injury or something, then we will go on to the aspect of filing a complaint and even taking legal actions against the patient. Right. Of course, actually, very important is to promote harmony. I think before we that and we have a group of patients that we call SPAN, the Sing Health Patient Advocacy Network. That is very helpful to say that, well, why not we make sure that there's harmony, and all these patients will be role models for patients who are not so well behaved. And we have co-produced and co-create the Patient and Healthcare Team Care Pledge, listed here: safeguard, communicate, respect, inform, partner, and trust. We even have a video, you can watch it, the video where we come together to be able to safeguard and respect each other. Now, just before I'd just like to mention some of the programs that we have right here. So I won't go into detail, but I will go into one of them, which is the Team Joy program, because this Team Joy is actually a program that we meant for team leaders. A lot of them are leaders. As I mentioned, leaders, the most one, to build a healthy and joyful physical and psychological workplace for their staff, right? And the leaders are role model, right? They can encourage their team members to attend programs, and they can also help them out through the hardship itself. And there are many programs that can help our staff, as listed here: mindful programs, our Team Tribe programs, right? So this is the Team Joy program that works through. And in this program, the leaders play a very important, because they actually comes down and discuss with the participants who are team leaders, and we do role play of appreciative inquiry. We give real contextualized examples where things doesn't go well and how to deal with it. So we even have an acronym called looking at civility, promoting it, appreciating your staff, looking at how you can enhance your policy, look at policy to embed joy at work for your staff, and using the appreciative inquiry approach. So these are the details relating to each of the approach that we have: civility, appreciation, policies and plans, and appreciative inquiry. And we look at policies that we have. In fact, a lot of policies are buried, but I think it's important to bring it out such that they can help the staff. So this is Sing Health HQ staff. They do have a team building appreciation, which is part of their policies. This is KK. They have a workplace bullying policy itself. SKH Sengkang Hospital, General Hospital, has a mindfulness as part of their policy to go through, and there are mindfulness sessions a lot that has been conducted. This is the SGH in terms of their programs for well-being at work. So just to finish that, well, it's not that bleak. We did, after all these activities, we find out that our burnout rates does improve. From 43.9 to lower now, it's like 40.8%. So there is a significant improvement, and the care is getting more complex. And it is important to keep a handle on it so that you don't get run away with that. And we look at whether we are increasing or decreasing. And so in terms of burnout, we have decreased it, but personal accomplishment, the lack of it, has actually increased. And we also look at empathy. We are not happy with empathy. Perhaps there are many issues relating to empathy that we can work on. So in conclusion, leadership is important. It is for a comprehensive and dynamic actions to address burnout, well-being. There are different components to work on, and they need to be prioritized. Different population segments, different strokes for different folks itself. And you need to look at all levels, especially the junior staff. The whole issue about doing it is that it's actually that quality improvement, a continual process that we keep on doing it to address this very complex, evolving issue. And with that, I thank you very much for your attention. Thank you.